Welcome to Inside Medical Malpractice. My name is Chris Rokosh. I'm a registered nurse, legal consultant and educator, and the president of Connect Medical Legal Experts. Each month, we'll be looking at malpractice issues from different perspectives, featuring honest, candid, insightful interviews by people and professionals with a wealth of information to share. Thanks for spending time with me today. Now let's dive into this fascinating subject. We're back today with a fascinating episode of Inside Medical Malpractice. We're going to talk about dental malpractice. Our guest today is a dentist, a professor, a dental malpractice expert on this very interesting subject that I think most of us know very little about. I met Dr. Rick Rayman, who you are all going to meet in just a moment, when I was approached through my company, Connect Medical Legal Experts, to find an expert to give opinion, an expert dentist, to give opinion on a case where some dental procedures had gone wrong. And I asked around, who would be great, who's smart, who's experienced, who's a good teacher, and was directed to Dr. Rayman. So that's how we met. We've been working together for years because he's been an expert multiple times on cases across the country for us. And the minute I first spoke with him, I recognized quickly that his depth of knowledge and experience would make him a great expert. The way he presents the information that he has, the manner and both the manner and the words that he uses, he's a great teacher, which is a key component of being a great expert witness, to be able to teach the courts what the standard of care issues are or the causation issues. And he's a pretty much all-around good guy. We have had a lot of conversations that had nothing to do with the work that we've done together on a professional level that have been very enjoyable and very fun. And I feel privileged to both know him as a person and a professional that I work with through the company. Dr. Raymond's talking to us today from Toronto. He's in his home. We're still kind of in the midst of the COVID shutdown, so things are a little bit different than we'd like them to be. I'm here once again with producer Steve at Wind Sparks Fly Production Studios in Calgary. Steve's in another room, and I'm sitting here. But let's do a nice introduction to Dr. Raymond and then get started, because he's got some great stuff to say. Dr. Raymond was in a private dental practice in Toronto from 1971 to 2012. He's been teaching at the University of Toronto in the Faculty of Dentistry since 1987, and he's still there. He was a clinical coordinator in a comprehensive care clinic from 2003 until present, an instructor in the oral diagnosis clinic, the emergency clinic, the comprehensive care program. He's currently the director of student life, a position that he's held since 2014. He's a facilitator in the Ethics and Law program at the University of Toronto and a member of multiple committees on faculty, including wellness, professionalism, student-staff relations, academic standing, undergrad education, undergrad awards, graduate education. He was a member of the RCDSO Quality Assurance Committee from 2010 to 12. And he's a dental consultant, or was a dental consultant with Manulife and Prudential Insurance Companies from 1982 to 1986. Welcome, Dr. Raymond. I'm so glad to have you here.
Thank you very, very much, Chris. That was a wonderful introduction. I'll remember that for a long time. Thank you. And it's a pleasure to be here. So I look forward to chatting with you whenever you're ready to start talking. Right. I'm here.
Good. Well, let's just start. I have some questions I'd like to ask you, but also just give you the freedom to speak and take this conversation in whatever direction you feel it should go. Because I would imagine that for many, many people, today is the first time they're hearing a conversation on this particular subject of dental malpractice, and you're a great person to give it. So let's just start with a general question. I was so grateful to find you when I needed a dental malpractice expert for something that was going on, a lawsuit that had happened. What motivated you to become a dental malpractice expert?
So this was probably one of the more difficult questions, but I think you sort of summarized it perfectly, but I'll leave the most important to the end. So being in private practice, in a busy practice in Toronto for almost 40 years, I saw and experienced an awful lot. Good stuff, bad stuff. I have really one issue myself, not related to a patient issue. It was more a staff issue, but I learned a lot from that, and also from my patients and my time in general practice. Like you said, I worked for two large insurance companies in the late 80s, and when I started teaching, like you mentioned, I was in our emergency and oral medicine, oral diagnosis clinic, but my time there has evolved, my roles there, I should say, and for a couple of years, I was director of comprehensive care, and which was a crucial position in the school, and I could talk for hours about what that involves. But now I am, as you mentioned, director of student life, and the most important aspect of what I do now regarding dental malpractice is I'm a clinical coordinator 3 days a week in our comprehensive care clinic with DDS 4, like our fourth year students who are in their last year. So besides that, I'm also, as you mentioned, a facilitator for DDS 3 and 4 in their ethics and the law program. And I also, I'm a facilitator for our patient-based learning seminars with our senior students, where we listen to and read a ton of evidence. So all that said, when I'm in the clinic, what I do, I help students and patients come up with our treatment plans. So I hear the treatment plan being presented with evidence and radiographs and medical history, and I'll talk about everything later on, to the patient. I hear the patient's input and mine, of course, and from that, what I see and how I evolved into being an expert, I see what has been successful, what has failed. I have heard complaints from patients ranging from this didn't work to this hurts to I want my money back. And so from everything put together and from seeing this, hearing this, from learning evidence in our seminars and from our ethics and the law program, which I'll talk about later, I guess that's how I evolved. It was a perfect scenario to sort of do this.
That sounds fascinating. And I've heard so many people say that, but you are a perfect example of how your clinical and life experience prepares you for something, and you may not even know what it's preparing you for, but when that opportunity shows up, you realize that many things that you've done up until this point have prepared you perfectly to do what you're going to do next, which in this case was to do some expert witness work. And I so appreciate what you just said there about seeing the outcomes and the successes and the failures of the treatment plans and the care plans and the treatment, because I think, I just know from my own experience being in acute care and talking to other doctors and nurses, we often don't find out how things turned out. You hope that what you did fixed the problem, but, unless the patient comes back to it or you have that level of follow-up, you can't really evaluate the effectiveness of your own care until or unless you've got that feedback. And hopefully it isn't just negative feedback when it comes back. So just so we can all get a really good context about you and the work you're doing in medical malpractice, could you share with us some examples of a couple of cases that you've been involved in?
Okay, so I can talk about two two excellent cases, and both to me are fascinating. So one, I guess I can talk about the one that took place a couple of years ago. So to make a long story short, a patient had an acute problem with tooth number 36, which is a lower left first molar. The dentist, I assume, and I can't remember exactly, came up with a diagnosis that led him to start a root canal procedure on tooth number 36. The patient was a longtime patient of this dentist, and obviously there was total trust. So root canal, I guess if you're an experienced clinician or an endodontist, somebody who specializes in root canal, you can do the root canal with a proper diagnosis and proper radiographs and subjectives and objective tests quite quickly and efficiently, but not always. In this case, the patient kept returning to this dentist regularly, almost once a month, and the dentist who was doing the root canal through a crown, which makes the treatment a little more complex, kept cleaning out, as he put it, the canals and placing medication and so on and so forth. Believe it or not, this went on for over 2 years without a referral, which is huge, and I probably shouldn't have said that right away. But after, and reading the records, after over 2 years, the dentist said he noticed a crack in the mesial root of tooth number 36, which is the front root. So what he did, he removed the crown and he amputated that root. So now the third molar was left with just the back root. We call it the distal root. And what the dentist did then, and again, the patient was totally compliant with this, he placed a crown on that root to fill the whole space. But I guess because it was ongoing for 2 years, he forgot that in his notes he said that there was a possible crack in this root also. But he forgot, placed the crown, that fractured within a month. So the patient he had to extract that root. The patient was left with nothing. The dentist subsequently placed an implant, and all I know, I'm not sure what happened with the implant, but also because of all this, the patient was left with a paresthesia that went on for a significant amount of time. So basically, what my issue was, why wasn't this patient referred to an endodontist, a specialist, much, much, much earlier on? And again, why was this crown placed on a root where there was a suspected crack? And why wasn't an oral surgeon called in to help this dentist with the placement of the implant and so on? So I don't know the results of this, but again, a referral should have been made 2 years earlier, in my opinion.
So a quick question just for clarification for our non-medical listeners. Well, first of all, I appreciate that you're just explaining what medial and tooth 36 and medial and distal and tooth, because, we all hear that at the dentist and I have no idea what most of it means. So I'm learning a lot just by listening to you today. But talk to us about what paresthesia means. And when you said this patient had significant paresthesia, explain that to us.
Great question. And paresthesia, to freeze, for lack of any other term, a lower tooth, especially a back one, you give an injection called an inferior alveolar nerve block. We call it a mandibular block. Depending on the technique and so on, and it's not uncommon, and people will know that their lip becomes numb. It should dissipate within 2-3 hours,
right,
and so on. Very rarely it can be prolonged for a day or 2 or 3. A true paresthesia stays for months. It's quite rare. You don't need to put it in your informed consent when you give this block, because of true paresthesia, I mean, the last time I looked at evidence was over the chances of getting it are so slim that it doesn't need to be put in one's informed consent. But this patient, because she had so many blocks in that area, developed the paresthesia.
Oh, I see. And how then did it affect this patient? I mean, I know what it feels like, and that you drool and you can't talk right, and you bite your own lip. You bite your own lip too many times.
Exactly. Yeah. Your tongue is numb, your lip is numb, and I think the statistics, and our dean is an dental anesthesiologist. So I know he's not listening, but I think it's 1 in 800 or 1 in 900,000 times. So it's very, very rare, and it's interesting because I ask our students all the time, do you have to put this in your informed consent? And they know not to, but there's certain times you do have to, and I'm getting off topic. If somebody plays a clarinet in the orchestra or is a wine taster, they have to know that there's a possibility of paresthesia. But it's very rare, and it's rare, but in this case, the patient had it for a prolonged period of time.
I see. So let's drill down into this case just a little bit. Talk about the allegations, and then I'm also interested to hear the defense position on this, if you know it, the allegations in this case.
Well, again, the paresthesia was an issue. The fact that she returned multiple times without a referral. The fact that when the mesial root, that front root, was extracted by the dentist, it took a copious amount of time, and then the failure of his other treatment, placing that crown over a small root that he, in his records that I read and pointed out, he said he suspected a crack. If you suspect a crack, you don't place a crown on a little root. As far as the defense, I didn't hear, but after my report, that was it. So it was either, and I don't know if it was settled, but I never heard back from the lawyer I was working with.
I see.
So I assume it was settled.
Yeah. Well, interesting. I'm, like I said, learning a lot, and also going for a crown next week. So I'm just having
as long as is it a back tooth?
It's a back tooth, and it's a cracked tooth. So I'm going to call you after this. We're going to talk.
It depends on the crack.
Yeah, of course. Okay, good. I'm going to phone you next week before I go to my appointment. We'll have a chat about this. So
as long as the roots aren't cracked, or the crack doesn't go subgingival below the gum, it's fine. So, but I'm sure your dentist is well aware.
Yes. Thank you for that. Thank you for that bit of reassurance. So you've talked, when we look at this case, there's a failure to refer, and it sounds like you've got some issues with the level of, some of the actual treatment decisions that were made. What are some of the other biggest issues that are problematic in both dental practice and dental malpractice today?
Very easy, and I'd love to talk about another case, which I can, but this I think is crucial. So it's interesting. One of the biggest complaints that I guess regulatory bodies get is communication. Dentists hopefully are good communicators. And when I teach a student, and I'm going to list some of the other issues, but, I tell them this, that I can teach, and I'm not trying to be funny here, I can teach our gardener how to prepare a crown. But what makes a good dentist is having all the non-clinical skills, like being kind, compassionate, showing empathy, and being a good communicator and a good listener. So that's crucial. So some of the other huge issues are, as we know, are record keeping and documentation. And some of the cases that I've seen, and one that I'll discuss in a couple of minutes if you would allow me, the record keeping and documentation were non-existent, as was the next topic or issue, which is informed consent. And I still tell students or suggest that treatment planning and your informed consent are the two most important aspects of good dentistry. So, again, informed consent, obviously taking an accurate medical history and discussing it, not just having a patient check off little things, but discussing what they put down in their medical history, which a lot of dentists don't. Obviously, diagnosis is huge. Practicing, and this is massive, I think, practicing within your scope of expertise will save a lot of problems. And if I could just mention this in that regard, if a dentist refers a patient to an endodontist, a root canal specialist, to do a difficult root canal procedure that he or she feels is a little too complex, the referral was made, everything good so far, but if the patient returns in 2 weeks saying, I went to your referring dentist you referred me to, the endodontist, but I can't afford his fee or her fee, would you do this root canal? Some dentists will say, yeah, I will to help you out, but you're going outside of your expertise, even with proper informed consent. You made that referral because a little too complex. Now, in my opinion, I don't think you should be doing it. So staying within your scope is huge.
Sure. And I guess that issue of fees, and for people who are insured or underinsured, it's similar to, I think, the U.S. healthcare system. And I know a vet who said that there's ethical issues that come along with whether or not patients can afford treatment or not, and then how to get them the correct treatment or the best possible outcomes. So I appreciate that you said that. That isn't actually something I'd thought of before, but it's certainly, it's been a deciding factor in some issues I've made myself about dental care. It has, It's
huge. And I have arguments with different instructors or colleagues that I teach with about doing free dentistry. Some are in favor of it. I'm very leery of it. You sort of want to help somebody out, but if somebody can't afford to, I'm not talking about a front tooth now, and I'm being very honest. If somebody can't afford a root canal on a second molar, and a crown that follows that procedure, then maybe you extract the tooth. Life will go on without a second molar. I'm not talking about a front tooth because there's cosmetic issues.
Yeah.
But, you have to be realistic. And dentistry is expensive, as we know. But the issue of free dentistry, pro bono work is a topic for another day.
Yeah, for sure. So just one step back to that scenario that you gave where the dentist refers to the endodontist, patient can't afford the endodontist. Like, what's the right thing for a dentist to do in that situation? and I know right is a big word and a subjective word, but how, in the context of malpractice and or avoiding complaints and certainly lawsuits?
So here's the issue, and I hope I'm not being too dental here, but say it's a back tooth, patient has limited opening, the canals are difficult to see on a radiograph, the roots are curved. All this would mean it's work for a specialist. If a patient comes back to you and said, no, I can't afford it, I want you to do it, even if you put down in your informed consent, I suggested a referral to an endodontist, because of this reason, that reason, so on, curved canals, calcified canals, but the patient wants me to do it, understands that this might fail. And now, let's say you go ahead and you do perforate, you do, because the canals are curved, your instruments come out the side of the tooth either will have to be fixed up by a specialist or extracted. I don't think you have much to stand on, because somebody would say, you knew you shouldn't be doing it. When I talked to my patients, who had been coming to me for years, they trusted me. So, you knew you shouldn't have done it. Any regulatory body, I'm not talking about legal now, would say you knew you are possibly harming your patient by doing this. Why did you start it? So that's my feeling.
Yeah.
And like I said, a back tooth is easy. A front tooth, it gets a little more complicated. But the good thing, front teeth and premolars, the ones that show, are a little easier to do. But if a patient can't afford treatment, it's a tough issue, because we know after root canal, most root canal treated teeth need extensive restorative procedures like crowns, which add to the expense.
Right. So that is two tough spots to be in, I could say, to either perhaps leave the patient without any treatment at all, which could lead to a negative outcome of some sort, as we know, or to try and treat them yourself.
Or extract the tooth.
Or extract the tooth. That's right. I would imagine, I'm just listening to you talk about how the treatment plan is, on this one story, the treatment plan is changing multiple times. So I would imagine the responsibility to get informed consent is an ongoing scenario. Is that correct? Totally. Yeah.
So I'm thinking about that case, and
well, let's go into. Oh, sorry. Are you ready to go into the second case, or are you referring?
I would love to, because the second case is a little easier, and the front part is a little easier. What is going to come of it is more complex, but involves not only dentists but medical specialists. So a patient came to a dentist for the first time, and this patient doesn't go regularly to a dentist. But the patient came in with a chief complaint of pain in an upper first molar on the left. So his complaint was pain. It hurt him at night. And when the dentist looked at this tooth, there was a lot of decay. The dentist did not take a radiograph yet. There was a medical history filled out, but just with check marks. There was no discussion of the medical history. And the patient, again, his chief complaint was pain at night. And there was sensitivity. His next complaint was some sensitivity to cold. And that's it. in the dentist's documentation, here's what was written down. Tooth number 26, which is the molar on the top left, first molar. There was pain at night. When I tapped the tooth, it hurt. And there was decay on the top of the tooth and the front of the tooth. No radiograph was taken yet. That was his only documentation. He then went on to say, my diagnosis, and I'm going to be a little dental here, irreversible pulpitis, which means the nerve of the tooth, the pulp, was inflamed irreversibly, meaning it won't get better unless you did a root canal procedure. So his diagnosis based on pain at night, it hurt to tapping the tooth, and there was sensitivity to cold. The dentist diagnosed it as irreversible pulpitis. He then went on in his 8-line informed consent documentation saying options were given: extraction or root canal. Patient chose the root canal. He did the first stage or first step of the root canal procedure, which is called the pulpectomy. He removed 3 canals, and I'll come back to that. He put medication in the tooth, and what was not discussed at all in the informed consent, the patient was leaving the next day or in 2 days to go somewhere for 1 month. So the patient, I didn't initially say this, the patient came in asking for an extraction, not for a root canal. So I have issues here with the informed consent, which to me was non-existent, and I'll come back to that. I have issues with the patient wanting the tooth to be extracted, knowing that the patient was going to be away for a month. And again, I'm trying to think. I mentioned that he removed the nerves from 3 canals. Upper first molars have 4 canals 95% of the time, but that's not an issue. Well, it is an issue, but that's the least of my concerns right now. But in his informed consent, a dentist or any informed consent, you should talk about the procedure that's going to be done, the reasons that you're doing it, the benefits, the risks, other options, or other procedures that could be done, so options and costs. Absolutely none of this was discussed, except 1 word, extraction, 2 words, root canal. So why this is so important, and the dentist probably did a good job in doing the first stage of the root canal. But if I'm at liberty to say this, while the patient was away, and this gets beyond my expertise, he developed a severe brain abscess. He's still sick to this day. Is there a link between the root canal and the brain abscess? It is now in the hands of infectious disease expert to see if there's a link. In my experience, I've never seen a brain abscess resulting from a root canal. The people, endodontist, oral surgeons I have talked to, agree I guess it's possible, but I wouldn't get into that. It'll be up to the infectious disease expert. But again, no informed consent, poor documentation, and does it breach the standard of care? Maybe not in his treatment, but in his decision making. So, very interesting case. I hope I didn't talk too long about that.
No, it's really, I have a couple of questions. I thought you said that the dentist opted to do a root canal, but you also have information that the patient came in asking for extraction.
Yeah.
Did you say that? So what happened there? Do you know? Is it he said, she said?
The dentist, remember I said a few minutes ago, my patient trusted me. If I told them to run around the block, they would do it.
I would too, probably right now. And I don't run.
Yeah, maybe. But we can talk about that later.
Yeah.
But so he came, the dentist said, and this wasn't in his notes, this came out later, but the discovery I'm not going to talk about because it happened many years later, but the dentist said, the patient did ask for an extraction, but I said this is a tooth that could be saved, so why don't you save it? But again, there was no discussion about the risks, the benefits, that he would need a filling in the tooth afterwards, he'd need a crown afterwards, and so on. And especially going away for a month or even 3 weeks, a more informed consent has to be given with what the sequelae could arise. But none of this was done.
Sure.
Now, again, the dentist probably did a decent job removing the inflamed nerves and medicating the tooth, but it's more in his decision making.
Sure. I have another question too, just to make sense of the story in my own head. So we've got a painful tooth, we've got a root canal, and we've got a brain abscess. Your thinking, and perhaps your colleagues' thinking, is those two things may be connected, a root canal with a brain abscess, but in your experience, it's unlikely. I mean, nothing's impossible, but unlikely. So how did that connection get made? That
and
I
it's
had a root canal.
very interesting, and that is a great topic to discuss. In what I read in the medical reports, and they were numerous pages way beyond my expertise, way beyond. But twice it was mentioned that a brain abscess developed subsequent to a root canal procedure. Mm-hmm. Now, at no point did they say this was the etiology, but subsequent to a root canal procedure.
Oh, I see.
I guess if I can say this, if there is no link between the root canal and the brain abscess, and I can talk more about that in a minute, I think the whole case will be dropped because the breach of standard of care is, I don't think would, I'm not a lawyer, but I don't think would help the patient at all.
They have to prove causation, right? They have to prove,
exactly.
They have to connect the root canal to the brain abscess. That is a very interesting and very sad story, and it will be really fascinating to hear how that all turns out. I would imagine when serious issues occur after dental work, there's quite often an overlap with medical healthcare providers because they require ER visits, hospitalization, pain control, sometimes surgical intervention. First of all, when you're giving an expert opinion on dental issues, are you ever asked to comment on the care provided by doctors and nurses or other people that are referred to outside of the dentistry world? And what is your experience on how that handoff goes between dentistry and medicine? Is that a smooth transition point? Or are there issues and posturing and hierarchy, things that we perhaps need to be aware of?
It's very interesting. I've never been asked to comment on medical or nursing care, and I'd be very cautious because I'm not there and so on and so forth. And I hear an awful lot. My son-in-law is chief of anesthesia at a big hospital in Toronto, and he's a young guy, so he's got he's doing great. But so I'm very careful to comment. But in a situation like this, and I'm not being critical, but the medical or the physician, whoever, there should have been, and this is lacking even in just dentistry, leave alone dentistry and medicine, there should have been some communication with the dentist. I mean, was the nerve alive, or was the nerve dead? Was there pre-existing infection? Did the patient have a sinus infection or a cold? I'm getting a little out of my realm, but was there a sinusitis, when the patient came in? But if the patient was totally healthy, no drug abuse, no trauma, and this nerve was a total vital nerve, total alive, with no infection at the apex or the roots of the tooth, no sinus infection, I think the link to a brain abscess would be, I've said it a few times, I'm just a dentist. I don't see there being any connection. And in talking to many endodontists, not many, but a number, and that's why I'm blessed to be at the dental school. I'm surrounded by specialists and people with a tremendous amount of knowledge. No endodontist has ever seen a brain abscess resulting from a root canal. And just like we talked about paresthesias, no endodontist would put this in their informed consent that the risks of doing a root canal, you're going to say pain, swelling, fracture. You're not going to say a brain abscess.
Right, of course.
So it'll be interesting to hear the results of this when the infectious disease expert looks at it.
And I'm only speaking from my own experience, is that I know very little about when you're talking about the teeth and the issues of the nerves and it's not quite Greek to me, but it's not nearly as understandable to me as it is otherwise. So so what you're saying there basically is that the communication between medicine and dentistry could be improved at these moments when there's a handoff of care, especially in care and ongoing treatment. Yeah, that's really good. I really appreciate that. So I want to just switch topics a little bit, but still within this topic of dental malpractice. You're an online facilitator for ethics and law for dental students at the U of T. I'd be really interested to hear if the ethical issues in student dentistry align with or perhaps predict the types of issues that later lead to dental malpractice cases.
For sure. And I'll tell you some of the issues. And we just finished one of our online, one of our ethics and law courses, and it was obviously all online because of COVID. And I'll tell you some of the issues. And I was thinking about this in the morning. So one of the issues that we always, in one of the modules, we talk about if a patient comes in to your office with a lot of amalgam silver fillings in their mouth. And we see this all the time. They're good amalgams. They've been there for years. There's no decay, no pain, but a patient will ask a dentist, and again, this is what students have to answer. A patient will say, I heard amalgams are dangerous because of mercury. Can you change all my fillings into resins, into white fillings?
Oh, yeah, so this is a big topic.
It's huge, and a dentist can make a ton of money. But should you do that? Now, if a patient can prove they have a true allergy, that's different. So that's one issue, or one topic we talk about. So on the same vein, a patient will come in to see to our clinic to see a student, and we see a lot of this, or a dentist, and they have a mouthful of decay all over. We call it rampant caries or rampant decay, but they say, I don't care about the teeth in the back. I don't care about my decay. I just want my front 2 teeth crowned because they don't look nice.
Right.
Should you do that?
Right.
Of course not. But so I let students give me scenarios, but you see that in real life.
Why shouldn't you do that?
Why shouldn't? Well,
Yeah.
good question.
Yeah.
So if somebody has rampant decay all over, when you do these crowns on front teeth, it's inevitable there's going to be decay around these teeth within a couple of years, and a patient is going to come back to you and say, or me, how come I developed decay around these teeth? What you have to do before you get on to doing crowns and bridges, you have to take care of the disease phase of dentistry, which is eliminating all the decay, working on diet, working on reducing or lowering somebody's caries risk, and taking care of their gum issues and so on. You can't jump into complex dentistry, yet dentists do it.
Sure. Oh, wait. Well, cosmetic dentistry is a thing, isn't it? You know?
Well, we don't let students get on to phase 2 until phase 1, which is disease phase, which is complete. So, I mean, it's done, but we see it all the time. You know, they'll come in with tons of gum issues, periodontal issues, but they want veneers. And I'm sure some dentists do it, but hopefully students are taught. And what I'm learning from being an expert witness, hopefully, is helping the future generation of dentists.
Sure. Dive a little deeper into that. What have you learned by being an expert witness, and how has that changed your education of students?
Well, not in any order. Practicing within your scope.
Yep.
And I'm going to talk about one topic I haven't mentioned yet, but I will in a minute. Practicing within your expertise, your scope of competence, informed consent, record keeping, accurate medical histories, pristine documentation, and make sure a patient understands. And you can't overwhelm a patient with 10 different options. Patients have to ask questions, and that's important, and you have to answer them calmly and slowly. So another huge issue, and what I've learned from all this too, and so I'll give you a good example. There's 2 words called informed dismissal. So let's say a patient who has some real bad teeth, but yet some real good teeth. But they come into your office saying, I'm tired of going to a dentist. I want all my teeth extracted, and I want dentures put in, because in the future I want implants. And we see this all the time in dental school, but yet a lot of these patients haven't worked in years, don't have much money, and you've got to listen to a patient's specific modifiers. Do they have finances to pay for dentistry? Can they visit you regularly? Are they going to be compliant, and so on and so forth? But so if a patient wants all their teeth removed, and even though there's a lot of good teeth that you can make some partial dentures and they say, no, I want all my teeth extracted, you don't have to do this. You can dismiss this patient, and the term is informed dismissal. You can explain why you're going to say, I'm not doing it, and there is a whole protocol on how to dismiss a patient. It's got to be a letter. Again, you have to take care of the patient until they find another dentist. You have to make sure their records are transferred, and there's 4 or 5 points. I can't remember all now, but that you have to write to this patient. It has to be documented on why you're not treating them. So I've learned from what I've seen, you don't need to do what a patient asks if you don't think it's correct.
Sure. That's how does that normally play out? Like, what is the typical response from a patient when I'm going to use the word fire, but you know what I'm talking about, when you say I'm not, and I can't, and I won't, and how does that go?
They're not happy,
yeah.
And it hasn't happened too often. It didn't happen in my practice. I guess I was blessed. I didn't have that many issues, like I said at the onset. But when I see it at the dental school, patients get really upset, and they start yelling at me as the coordinator, saying, "Are you trying to get rid of us or me?" and so on, or "I can't afford." But I use the same line every time. We're trying to help you. We're not trying to do anything to make it harder for you. And I also say there are 10,000 dentists in Ontario. So that's a lot of dentists, isn't it? There are more lawyers than dentists. So.
That's right. So that sounds like a pretty difficult conversation to have. But I want to ask you about another potentially difficult conversation. From my perspective, when I started doing expert witness work, there were some personal issues for me to overcome in speaking out against my colleagues. And I make sense of it in my own mind by fully and truly believing that what I'm doing is not speaking out against nurses or healthcare, but standing up for and withholding excellence and the standard of care. But all that aside, before I even had words to say that out loud to people, when my colleagues and friends and even family learned that I had chosen to become an expert witness, and some of that work involved working with plaintiff lawyers and speaking out or, giving expert opinion that the nurses had not met the standard of care in certain situations. I mean, that was hard for me, but I also got some backlash. Some people loved it and said, fight the good fight and do what needs done. Your professional associations task you with speaking out against substandard care. But other people were very critical and said they don't know. If they were my boss, they would fire me immediately, and they didn't know how I could do it, and how did I sleep at night. And then there were other people who I was just met with this tremendous amount of silence, which I always interpreted as negative judgment. I may be wrong in that, but at the time I was like, well, if it's not good, I'm pretty sure it's bad. So have you... Two questions. Do you find it difficult to speak out against colleagues or dentistry or, stand up for the standard of care, however you want to word that in your mind? But also, have you received any backlash or criticism for the medical legal work that you've done? So
two parts. I'll give you an example of the second part of your question in a minute. Until I guess you mentioned that, and I really have no issues. If I see something that I think is totally off base coming from a patient, I'll mention it. But every case I've done so far, after sending in my report, or talking to lawyers and so on, and all the lawyers I've worked with have been just phenomenal so far, and I've learned tons from them. But after sending in my report, whatever it may say, I slept fine that night. So it didn't keep me up. And I try not to discuss too much of this because I'm surrounded by dentists. I do, when cases are finished, with maintaining confidentiality 100%, I do discuss, or not, they don't know their cases, but with students, and not one student have said to me, Dr. Raymond, why are you doing this, speaking against other dentists? But I guess they're not at that level yet. But with respect to that case, that second case we just spoke about, that root canal and a 2-6 in the brain abscess, one endodontist said to me, and this is a friend of mine, I don't think he'll be a friend anymore, but he did say to me, this guy did a good job. He spent an hour and a half. Leave him alone. What are you trying to make it hard for him? So there's somebody who felt this dentist tried his best. Maybe he did, but there were still inadequacies in his, as we mentioned, informed consent, medical history, diagnosis, and so on. So if I could get back quickly to that case, with the test that dentist did, I wouldn't have, or most of the endodontists who I teach with the test that he did, they would not have started a root canal because it wasn't a complete diagnosis. But again, that's standard of care, which might never come to be, depending on what the doctors find. So it doesn't bother me, but I do get some backlash. But I try to not talk about these except to people I want their opinions, who are specialists in their field and who are also professional and friends, and will keep things obviously between us. So I do sleep at night.
Oh, good. I'm glad to hear that.
I have other worries, though, so.
Yeah, I know. We'll talk about those in a minute. I'm going to ask you what keeps you up at night when we talk about you on a little bit more personal level in the next podcast. But just 2 final comments about what you just said, and then I'm going to ask you 4 questions about bits of advice that you could give to all of us. I think that perception that malpractice exists or is just a bane of existence for healthcare is quite pervasive in dentistry and medicine, but it's missing the whole purpose of medical malpractice, which is to protect the consumer of healthcare who are harmed, but through no fault of their own, at the hands of healthcare providers, be they dentists or doctors or nurses or whatever. So I think a lot of doctors and nurses that I know are scared to death of litigation and think, and have sort of a sense that it exists to make their life miserable. But it's really there to protect the patient who's injured.
Right.
And, we have to all keep that in mind. Now, not that the end result isn't pretty darn miserable for the people who get sued, because I know for sure that it is. But what advice would you have to offer other dentists, perhaps, or healthcare experts of any sort that are maybe just playing around with the idea of getting into doing medical legal cases and providing expert opinion, but either scared or worried or wondering about this kind of backlash from colleagues?
So again, for patients, I think the public, I think they should be cautious. They have to ask questions. They can't be pushed into any type of treatment. If they don't understand, they should ask for a better explanation and for the dentist to go slow. It should be a dentist, not a treatment coordinator. It should be a professional, in my opinion. If they don't understand, they can ask for diagrams. They can ask the dentist, where can I find simple, readable layperson evidence? So a dentist could say to a patient, I can do this crown, but you're going to need crown lengthening. No layperson understands what crown lengthening is, but there's tons of ways to explain it so any layperson can understand. So a patient has to ask questions. They have to be comfortable. They have to know the risks, benefits. They have to know costs. They have to know alternatives. And there has to be total trust. And again, informed consent is ongoing. And they need time to think and so on. I guess I was sort of lucky when I was, out there. The internet wasn't so accessible. Now patients come to our school or to offices knowing more than, evidence than some dentists. But so that's for the patient. For a dentist, I think what's crucial, as we talked about, you have to have a good discussed medical history. You have to have a detailed, informed consent with, like I said, pristine documentation. You have to have a patient to, I guess, consent to each part of treatment. On one medical history that I read, right at the bottom of the medical history, it said, when you sign here, you're agreeing to any treatment that Dr. So-and-so is advising. That's a blanket consent.
Yeah.
So again, it doesn't make sense. So informed consent documentation, this is to a dentist. You have to do a proper diagnosis, subjective, and I'll come back to that, and objective tests. So with respect, if somebody comes in with a chief complaint of pain, you just can't say it hurt last night, the patient. You have to ask, when did it start? How long does it last? What brings it on? What relieves it? Or you take medication? And I could go on. And objective tests, most dentists would know.
I just like to add in there too that something you said very early on in our discussion was being kind and compassionate. And that is,
yes,
that is so true across the board, that patients are less likely to sue healthcare providers that they like.
It's funny you said that. That's my next comment.
Oh.
You have to show empathy and compassion.
Yes, yes, yes.
And if you don't, that's huge. I mean, non-clinical skills are, when I write reference letters for students, that's what I talk about. I mean, our students who are applying to specialties get good marks. I talk about them as a person. Nice. Do they show empathy? And you're right. If somebody is caring, boy, is that ever true, and shows compassion and empathy, there's a lot less likelihood there's going to be lawsuits and issues.
Yeah. From the patient perspective, it makes the experience so much better, too, for us.
Yeah, and I put that in my notes. I put show care and compassion and empathy.
Nice. Very good. So what advice would you offer to doctors, for instance, who are receiving the care of a patient who's got some dental issues following treatment?
Like we said, I think doctors are so busy, and I understand that, but there has to be better communication. So, if somebody comes into our office or school rather, and they have type 2 diabetes or are hypertensive that we think is uncontrolled, we'll send a medical letter. And most doctors, when they're ready, will send back a letter saying okay to treat and so on and so forth. But maybe what we've improved our letters, we say that these are the medical conditions, these are the medications that are the patient is taking, and these are the procedures that are being done. But I think if a medical doctor doesn't understand the procedures that we're doing, there should be better communication. So I just wish doctors, and I know how busy all family practitioners are and how difficult it is to even find one, but I wish there was better communication and a better understanding of what we're doing as dentists.
Sure. That's a fair ask, I think. And what about for lawyers? From all that you know and all you learned, what's the most valuable thing that you would want lawyers to know about dentistry and or dental malpractice?
Well, the lawyers that I've worked with so far, I don't know what I can say except they've been exceptional. They've listened to me. They've listened to the people that I have reached out to. I think I've learned a tremendous amount from them. I don't know what I can say to help them, but I guess they have to feel comfortable with their experts and that their experts are providing the proper information. That's a hard one because, like I said, I've been doing this for a number of years, and every lawyer, I guess, I don't know who will be listening, that I've worked with seems to get better. My son's a lawyer, but he doesn't do this stuff, so he didn't even want me saying that he's a lawyer, so he won't be listening anyways.
Too late.
So.
It's out there now. So one's an anesthetist and one's a lawyer.
I'm not supposed to say how he limits his practice, so he gets angry at me enough anyway. So, but I don't care. So.
So one tiny last question, because now I'm curious. What is crown lengthening? What is it? Crown
lengthening. Okay. So let's say you have a big filling on a tooth. Okay? Big filling.
Got it.
And part of the tooth breaks, and the dentist will tell you, and rightly so, with proper diagnosis and radiographs and tests, subjective, objective, you need a crown. But the filling that you have goes below your gum, okay? Do you follow what I mean? It goes below your gum.
Got it.
So, and it's worked so far, but when you do a crown, you have to finish the crown on real tooth. You can't finish it on a filling. So you have to remove that filling. But how will a dentist see that margin, where that filling ended, where he's got to put his crown margin? So what you have to do in some cases, if it's doable, and I don't want to get into the, I guess, contraindications, but a periodontist or gum specialist, or if a dentist feels they can do it, they'll remove some tissue and maybe a little bit of bone so that you now can see where that filling ended, and you can go below that to prepare your crown. So you're basically removing a little tissue, sometimes a little bit of bone. It's a common procedure. My daughter just had it, and it was very simplistic. And there's good ways of explaining it to lay people with diagrams.
Right.
And you know, I do the comprehensive care orals for graduating students at the end of fourth year, even though they were canceled this year. And that's one of the questions I ask. How do you explain to a layperson what crown lengthening is, or what an implant is? But that's a topic for another day.
Sure.
So,
and you did very well. I understood exactly what you said, and pretty much hoping I don't need that done, you know, not next week anyway.
Now, it doesn't have to be a periodontist. Some GPs are competent in doing it. I always sent mine to a specialist. And not all teeth need crown lengthening. It's case dependent.
Sure. Of course. So I know I said that was my last question, but I actually have one more for you that I started to get to and I don't think we got the answer to. What advice do you have for healthcare experts, dentists, doctors, anybody who might be toying around with the idea that they'd like to do some expert work, but are reluctant for some reason or another? What do you have to say to them?
Can I be honest as far as dental experts?
Yeah.
I'm not going to give any advice because I want to continue doing this. So I don't want too many experts out there. So that's the God honest truth. I can't be more honest.
Okay. Thank you. That's
if there's too many, you guys might forget about me. So
how could I forget about you? We talk almost every week. It's lovely.
But you can see I'm honest here, okay?
Yeah. So. But not very helpful. So let's talk. I mean, in the regard, like if there's a dentist, okay, let's say it's a doctor. Let's say it's not. If it's just a healthcare professional who's interested in the work, like I'm interested in what motivated you to become a dental malpractice expert. And no doubt you had to overcome some of your own concerns about how it would be in the high points and the low points. Do you have any advice to offer?
I really, to medical doctors, I can't, but for me, all I'm reading now, and it's upstairs, so I don't know the name of the book, but I'm buying all these books on dental professionalism, ethics, and the law, and so on. Unfortunately, everyone I bought so far are American publications, but I'm fascinated with the topic, and I better start reading more about treatment planning once we go back than this stuff. But that's all I've read so far all summer is ethics, the law, and professionalism as it relates to dentistry. And so I guess the advice to medical doctors is just get interested in this topic. I think it's truly fascinating, and it's not a dry topic. It's exciting to read some of these cases, except they're all American. But when one day in the future, I can tell you the names of some of the books I bought. But I'm going to definitely share them with my students, or our students. They're not my students. So just get involved and get interested in it. And I'm learning stuff every single day, talking to you guys, talking to lawyers, and, looking at discoveries. I think it's fascinating.
Yeah, I do too. I share that passion with you. But I'll tell you what is like one day in the future, you need to write that book about Canadian cases. How about that? There's a job for you.
You know what? There is a book that has been out for years, and I can't think of his name, so I don't want to. But when I went on Amazon, where you can get anything in the world, they said that book is out of stock.
We need a new one. Get busy.
I know. That would be a neat thing to think about in the future. I mean, it really would.
For sure.
Because we got good cases.
Yes, for sure. Well, we could talk for hours about this, but I think this is a really nice point to bring this conversation to a close. But a couple of things I just want to say. I've enjoyed knowing you up until this date, and hopefully more in the future, so much. I've learned so much from you. I so appreciate your expertise and your willingness to share your expertise in such an approachable, common sense way. And it's very obvious to me that you're passionate about both your work in the dental world and in the as a dental malpractice expert, and that just shines through with this conversation that we just had. So thank you so much.
Thank you. It's my pleasure. I love doing it.
You're so welcome. So let's call this a wrap, but we'll come back and do a shorter version in this where we talk more about Rick Rayman as a person and hear more about his life and what does keep him up at night, because he alluded that there is something. And if you're interested in the role of being an expert witness, don't be shy to contact me at any time. It's Chris Rokosh. I'm at Connect Medical Legal Experts. You can get in touch easily through the website. I'm on LinkedIn and easy to find. Or an email, info@connectmlx. You can find these podcasts on several different providers, Apple, Spotify. We're on iHeartRadio now. And we now have a new YouTube channel called Inside Medical Malpractice. So feel free to listen to everything. But let's wrap this up for today. And thank you once again, Dr. Rick Rayman.
Thank you.